All right, welcome guys. We're going to finish up chapter 14 here with a little bit on reassessment and what that means. So thus far we've talked about primary assessment. Actually, let me back that up. We've talked about scene size up, follow that up with the primary assessment. And then we start talking about the secondary assessment. And this is kind of the tail end of the secondary assessment and what we're doing there. And this is going to be what's called reassessment. Basically means we're doing things again, except it's a little bit different this time, just a little bit. So the reassessment, again, we've gone through our primary assessment, we've done that, we've gone through our secondary assessment, we've done all the steps there, and now we're following up with the tail end, it's the reassessment. So we're basically starting at the beginning again with our primary assessment, and then we'll go through our secondary assessment again. So when we do the reassessment, we're doing everything again. However, we've got all the information, all the detective work we've done with our initial primary assessment and our initial secondary assessment, all the information that we've gathered there, we have that this time. And so we're much more informed when we're doing our reassessment. So we can evaluate our patient's condition a little bit better. Hopefully we've got an idea of what's going on. We've made a field diagnosis of what's happening with our patient, done interventions, like giving some oxygen or medication, whatever it might be there. So we're doing this again with all the information that we've already taken in. So it's much shorter, and it can be much more focused than our primary and secondary assessments that we did initially, because we didn't have any information at that point. So these can be a little bit more focused. In the reassessment, we're looking to identify any changes and trends here. And what that means is, like, is the patient getting better? Are they staying the same? Are they getting worse? So we want to see the changes. Are our interventions working? Are they working well? Are they giving us the results that we hope for? Or, is it not working? Do we need to come up with a different plan of attack for the patient treatment there? And we always need to do a reassessment, right? Like our primary and secondary assessments, we have to do those. We always have to do those. However, the assessment is an ongoing process. It never stops while we're with the patient. And so we have to be aware that there could be changes, or that we should expect changes to happen based on our treatments, right? So hopefully they're getting better, or we can see changes in them getting worse. And so the assessment, it's a continuous thing that's happening while we're with the patient. Once we gather all the information from our primary and secondary assessments, and we're starting to do our reassessment, again, like, it can be more pointed, it can be a little bit more focused because we've got all that information there. And we always need to do it unless, right, this is just kind of like getting the repeat set of vital signs. You should always be doing it unless the situation dictates that we can't, because we're doing life-saving interventions, because we don't have enough manpower on scene, right? Maybe it's just you in the back of the ambulance, and you don't have the time or enough hands to do things. So we always need to be constantly reassessing. After we initially get some information, we need to reassess it, rethink about it, twirl it around in here, and make sure that our diagnoses are good, our interventions are good, etc., things like that. So we always need to be doing those. Again, we're looking for changes. They can be small, they can be large, right? For example, if you're giving somebody a little bit of oxygen, like, how much good is that little bit of oxygen doing? Is their mental status coming back with somebody who's like, highly altered because they're hypoxic? Just giving them some oxygen, is that a profound change? Is it just a little bit of a change there? We get somebody some glucose, right? Maybe they go from being completely altered because of low blood sugar, right? Low blood glucose, completely altered, basically not acting, maybe as an adult would. I think I told you about the story of the 70-year-old man, diabetic, who's naked on his bathroom floor, and all he could do was just be like, and that's it, right? You give him the the glucose, and a little bit later, he's conversing with you. He's able to tell you who he is, where he is, what time he is, all those good things. So like that's a profound change. So you have to be on the lookout for little teeny tiny changes and the big ones as well. So we're looking for that in our reassessment. Hopefully something has changed. Hopefully it's gotten better, but maybe it's still getting worse depending on the patient's condition. We've talked about trends, so we want to identify those. Again, that's getting a piece of information and then looking at that information a little bit later and seeing if it's better or worse than it was previously. So, for example, taking a set of vital signs, taking them a little while later, comparing the two there, so we know what trending is. And in trending, we're looking for deterioration or improvement there. It's pretty simple, I think, to go through that concept. Now, when we're reassessing the patient, obviously this entire time we're going to be communicating with the patient, both verbally, non-verbally, all of that. We have to become masters at our communication with the patient. We got to remember that this could very well be the worst day that they've ever had. So we need to help make them comfortable explaining what we're doing, explaining things like what we're thinking, and things like that, right? We want to be open, we want to be honest, we want to communicate clearly and freely with these people. It can, oftentimes it can help produce better patient outcomes because they trust us. They know that we're going to communicate with them. We can make them feel better just by how we're treating them, explaining things, right? Treating them like a human being rather than like a piece of chattel, right? Just a commodity there. So we're going to explain things to them as we've talked about. We'll explain everything that we're doing, and we need to keep in mind some of the things that we have to do, like when we talked about doing a rapid trauma assessment. Some of the things we have to do, it could cause embarrassment or anxiety. So let's say your patient, they have a multi-system trauma, right? They've got some big injuries. They're with it, right? Completely with it. And we have to cut their clothes off to be able to properly observe their injuries. So I don't know about you guys, but I'm pretty sure most people would probably feel embarrassed or anxious to have a bunch of strangers cut off your clothes and look at you naked. It can be an awkward situation. It really is for those patients. So we got to consider those kind of things, right? We got to, hey, listen, I'm gonna cut this shirt off of you so I can take a look at what's underneath there, right? I want to take a look at your abdomen, your chest, and everything, but I'm going to cover you back up. It's just for a minute, right? We have to consider their feelings and things like anxiety and embarrassment. So communicate well with your patient. It can help establish a better rapport between you, and again, it can lead to better patient outcomes because you have a patient that trusts you and can be more communicative. Excuse me. All right, so what are the steps of the reassessment? Basically, we're doing everything again. Primary assessment, secondary assessment. We'll take our vital signs again as well. Except that this time, as I said, we have all the information we've already gathered. So we're not going into this blind exactly like we did when we first approached the patient. Right? We've got a lot more information here. So our primary assessment can be a little bit more focused, or secondary assessment can be a little bit more focused because, again, we're much more informed at this point about the patient's condition, what we feel their priority is, what your gut feeling is, from your general impression and things like that. So we're going to repeat the primary assessment, which we won't spend too long on this, but we know what that is. We're going to look for any life-threatening problems. We're going to recheck for those. We'll reassess their mental status, right? AVPU. And then we're going to do our ABCs. We're going to open the airway. We're going to make sure that the breathing rate and quality is good. We're going to check their pulse, recheck circulation. We're going to be looking at their skin condition there as well. And then we're going to rethink about our priority. Will we correct? Can we lower it down? Is the patient getting worse? Do we have to readjust our priority for what has happened since our initial assessments there? So basically, again, same thing, primary assessment, secondary assessment. We'll be able to get through it a little bit more quickly this time because we're already informed. But this is redundancy here is a good thing. It's a good thing. It's not. We're not just doing this to. Sorry about the bell. We're not just doing this for the sake of doing it again, right? Things change, and we need to be aware of it, and we need to be leading the charge when it comes to taking care of these things and recognizing them, because the changes could be significant. They can be significantly good, or they could be significantly bad. And so we need to be on top of these things. So doing the reassessment, it's not doing it to just do it. And it's not just like checking a box. This is a real important part of it because of the changes, right? At this point, we've done things like interventions, right? We've been with the patient for a little bit longer. We should have an idea of what's going on with them. So we need to figure things out like, okay, was my guess on my diagnosis correct? Or are interventions correct? How are things changing? Has anything changed with our primary assessment? Our mental status, ABCs, priority, all that kind of stuff. So it's not just checking a box. This is an important step in getting through our patient care. We've talked about this before. So with an unresponsive child or infant, we'll check their mental status by yelling at them, right? Verbal, shouting out them, see if we get a response from verbal stimulus. And then we'll flick the soles of their feet. Right? Flicking the soles of their feet will be the painful stimulus. Okay, so we're not gonna, obviously sternal rubs are out for everybody. We're not gonna do the pen between the fingers. We're not gonna do the pressure point on the trapezius muscle back here, right? We're not doing things like that. We're just gonna be flicking the bottom of their feet, okay, for the pediatric. And we've talked about this also. Crying with kids is normal, and it's a great sign. So with a patient that has been hurt, a pediatric patient, you'd expect them to be upset and crying. And so when you get to a scene, say the kid that fell and hit his head, and he's not crying about it, you need to kind of have a high index of suspicion about that and figure out why. I mean, maybe he's okay and things are fine. However, maybe it's an altered mental status because of the injury that occurred to the head. So always take that quiet kid who's been hurt, right? If they're quiet, take that with a grain of salt. It doesn't necessarily mean they're okay. It could be a sign that things are bad. And this is also a great point to bring up, because when we're dealing with pediatric patients, we're also dealing with mom and dad, right? The parents or whomever the caregiver is, things like that. Every time that I've brought this up with a patient's parents, it actually brings them a little bit of comfort. And what that is that, mom and dad might be upset because the child has gotten hurt, and they're clearly upset. The child is upset. A thing that you can tell mom and dad is like, I love this. I'm not happy your kid got hurt, obviously, but I'm happy that they're crying because this is normal. And so I'm happy with this. So just take this crying as a great sign, as a good sign of their condition at the moment. Right? So this is good. Even though it's a young child crying, like, it should be music to your ears. We want to hear that kind of thing. So it could be abnormal that they're not. Maybe they're just a tough cookie, right? And they're not crying. But we got to figure that out. So take it, have a high index of suspicion that a child who has had traumatic injury not crying, take that as a sign of an altered mental status initially, and then we can back off from there. Like, kid's fine. He's a tough cookie. She's not crying. She's doing fine, whatever it might be. There. So the crying, expected response. We like it. And like I've told many patients' parents, like, this is music to my ears. This is great. I love that they're crying. This is a good sign for us. So hopefully that can assuage some feelings of anxiety and whatever else mom and dad might be feeling at that point. So that can definitely be helpful. All right, so when we're doing this, we're going to, this is where we'll do our repeat vital signs. We've already taken our vital signs at this point, and so we'll do our repeat vital signs, and we'll compare them with the baseline vitals that we've already taken. And this is where we can start seeing our trending, right? What did the blood pressure do? What did the heart rate do? What did the respiratory rate and quality do? Right, so what did the mental status, does it get better, get worse? Right? So this is where we're going to start seeing our trends. So after we get our primary and secondary assessment done, we can get those vital signs in there, and we'll reassess here, and we'll compare them again, starting our trending. So we're going to reevaluate everything. So we've already put the pulse ox on, so we're just going to take a peek at look at that again, make sure that it's still good. If we've given our patient oxygen, we want to see that those O2 sats going back up, right, to a more normal range there. So we're going to reevaluate oxygen therapy, and then we're going to obviously document all of the vital signs here, so we can show the trending there to the definitive help at the hospital. Let's see, we're going to repeat the pertinent parts of the history and the physical exam here. So, and this is where the information from our initial primary assessment and secondary assessment comes into play, because we're not going to have to do the whole thing. We can kind of focus, because this is the second time we're doing this coming through here. We have a lot of information. We know what the patient's chief complaint is, or at least initially. Maybe it's changed, but at least initially we know what that is. We know what the problem is, where the pain might be, where the injuries might be, things like that. And so we can kind of focus in more on that, rather than taking a more general approach that we did in our initial primary assessment and secondary assessments there. So just hit the pertinent parts there. Chief complaint, again, as I touched on, it may change because of the severity of injury. Things can change a bit there. So just keep an eye out. Good questions like, okay, so we initially came to your house for, let's say, chest pain. We initially came to your house, man, for chest pain. Is that still what's bothering you most right now? Or has things changed for you? Is there something else that's bothering you the most at this point? Right? So easy question to ask. Real easy question to ask. Now, we'll also ask them about their symptoms, right? So let's say we have a person that's having trouble breathing, and we've given them oxygen therapy. Well, after they've had it for a few minutes, you've got to check back in. Well, how are you feeling now? Are you still having trouble breathing? Questions like that. So touch back in with their chief complaint and their symptoms to see how they are. Maybe pain is diminished. Maybe things have changed there because of your treatments, because of just time. So we got to just check back in. Just check back in with their chief complaint and what their initial symptoms were, and see if things have changed. And if there are any changes, we have to document that. Right? We'll be able to document in our patient care reports these changes. So it's important to show that we did make progress with the patient. So just because somebody is having trouble breathing and they had low oxygen sats, say like 92, when we first got there, right, we have to document that things got better. We gave them, oxygen, and these were their oxygen sats afterwards, and the patient stated that they were feeling better because of it. Things like that. So we'll have to document those kind of things. So we're going to repeat the physical assessment, and this time it can be more focused on where the injuries happen to be. There we can do a general real quick head to toe to figure out if we've missed anything. Hopefully we haven't at that point, but we'll check back in with there any injuries and the pertinent history leading up to those to see if anything has changed. One of the things that could change is the patient may not have remembered everything when they were telling you things initially. Like, oh, you know what? I forgot when I fell, I did hit my head on the way down. I wasn't thinking, but I kind of feel it now. There's a little lump here or something like that, right? So you'll often find patients changing their stories a little bit once they've had a little bit of time to think about it, for that information to kind of settle in there. Okay, so we'll repeat the pertinent parts of the history and the physical exam. And we're going to check our interventions. I don't want to skip that. We're going to check our interventions. Is what we have done with the patient working, right? Is it working? Did our oxygen therapy work? Did the controlling bleeding work? Whatever your intervention may have been, is it working? Is it the good thing to do? Do we need to do something else? Or are we on a good path? So checking the interventions, again, along with our primary and secondary assessment, it's all important because things change. All right, so just like I said, checking interventions, O2, bleeding management, any other interventions, kind of make sure they're adequate, make sure things are good, and hopefully we're having good results as the result of our interventions with our patient here. All right, trends. And observing the trends and doing it, what we're going to do is we're going to repeat some of these assessment steps frequently. When we reassess them, I'm going to do things like document the time I checked back in. If I got to my patient at 1700, well, at 1710, this is how they were feeling. At 1720, this is how they're feeling, how their symptoms were, what the vital signs were, things like that. So establish the trends, get a baseline, and then start things trending. There, you know what I'm talking about. All right, so for reassessment for stable and unstable patients, their patient's condition, how long you have with them, will be large factors and play a role in how often we can reassess. If your patient lives 5 minutes from the hospital, you probably won't be able to, because it's just that you load them up in the ambulance, and before you know it, you're unloading them at the hospital. So time with the patient definitely plays into this. Their condition, things like, do you have enough people in the back with you? Are you too busy? Those kind of things can play a large role in how often we get to reassess and everything that we get to do. For the more serious patient, you're going to reassess more often. So general rule of thumb, just like vital signs, if you have a stable patient, every 15 minutes. If you have an unstable patient, we should be doing things every about 5 minutes. And the reason for the large change there is we want to be on top of any changes as they occur. And so maybe we can correct things like get more oxygen, stop bleeding, whatever it might be. So if it's unstable, every 5 minutes. If they're stable, every 15 minutes for that. All right, and those are just general guidelines, right? So if you have a stable patient and you got a few minutes to do it before you get to the hospital, but it's only been 10 minutes since you did it the initial time, you just go ahead and do it again. That's fine. You can squeeze it in there, right? Better to have more information than less. So they're guidelines, but every 5 minutes for somebody that is unstable or seriously hurt, multi-system trauma, things like that, every 5 minutes, you just got to stay on top of it. It's almost like a continuous cycle. You start it, once you finish, you're basically starting again and going through the whole cycle once again. Every 15 minutes, as we said, for stable, every 5 minutes for the unstable. And this is important, or the potentially unstable. And if your index is suspicion, if your antenna are going up like, oh, this could be a bad situation, and I'm not sure, I think things might take a turn for the worse here. Things are okay now, but they might take a turn for the worse. If you have that in your gut, then just do it every 5 minutes. So you can be aware of that change happening as it's happening rather than sometime after the fact, right? So every 15 for stable, every 5 for unstable. Again, these are general timelines. It's not like there's going to be an alarm going off in the back of the ambulance. We're like, oh, I got to reassess now, right? We got to reassess every patient, basically. We want to make sure we didn't miss anything. We want to identify any changes. We want to make sure that they're getting better and not worse. And so we got to be on kind of top of it, especially for those unstable patients. All right, we're going to talk a little bit about critical thinking and some decision making here as well. In the field, EMTs, any medical provider, basically makes a diagnosis. There's an argument that only doctors can diagnose, but that's a terrible and arrogant argument. Anybody can diagnose. Okay, you don't need to have massive student debt and 6 years of post grad to be able to diagnose somebody. You don't need that. Anybody can diagnose. Right? The untrained medical professional, the layman can diagnose. Right? If you fall down outside taking your garbage can to the curb, you slipped on ice and you broke your arm, and the bone's sticking out of the end. And when the garbage man comes by and is like, "You have a broken bone," guess what? That guy just made a diagnosis. Right? So don't think that you can't. Anybody can. Right? Now, the difference between us and doctors is that we often work under a time crunch. Right? Maybe we're only with the patient for half an hour, 20 minutes, something like that. And we have to get not only all of our history done there, I've got to figure out their history, ask them more questions and everything, right? Sample OPGRST. We have to try to do our interventions. We don't have x-ray machines. We don't have CT scanners. We don't have MRIs or anything like that in the back of the ambulance. And so they have the luxury of time oftentimes, and they have the luxury of resources that we could never have. But we can still make diagnoses. So we're going to make these based on their history, their vital signs, physical examination, their symptoms, and we're going to mix all that stuff up with all of our medical training. We're going to look at patterns, right? What happens? What are patterns? What am I talking about here? It's a patient has chest pain, right? There's easy patterns to recognize there. They have chest pain. It hurts. Sometimes it radiates. Sometimes they have trouble breathing. A lot of times they'll clutch their chest. Or the pain that they have, it's sharp, it's dull, it's crushing, right? Those things they all fit into the patterns of chest pain. And so we're going to start to recognize some patterns, and then those patterns can lead us down the path to the correct diagnosis there. So we're going to mix, like I said, vital signs, history, present condition, signs and symptoms. We're going to mix it all up with our medical training and our experiences there. So this involves both physical and intellectual activity. What that means is after our physical examination and talking with the patient and doing the detective work, that's when we all put it together and say, I think this is what is going on with the patient. And that's how you form a diagnosis. Forming a diagnosis, right? What we're generally going to have is what's called a field diagnosis or a working diagnosis. Right? We may not be able to prove 100% that somebody's condition. Maybe 99% sure based on patterns that we've seen, our medical training, their signs and symptoms, their past medical history and their pertinent medical history, the events leading up to wherever you are there. So some doctors, clinicians, they think it's a final diagnosis, right? We may not be able to quite get there because we don't have the tools and the time, and the technology that doctors in hospitals will have. But we can still make that field diagnosis there, which is important to do. Techniques vary, obviously. pattern recognition is, while it is an easy path to making diagnoses, you see somebody tripoding, that's it, right? Let's just say you see somebody tripoding. What's your diagnosis, right? Well, you're just going to say that they have trouble breathing. That's your diagnosis. That's your working diagnosis at the point. Well, maybe you can't say 100% why they're having the trouble breathing, but they are having the trouble breathing just based on your training there. So techniques vary. A lot of times we have to do the detective work. We have to infer some things there, but we can make solid, really good diagnoses in the field. So informing a diagnosis, there's a traditional approach. We assess the patient, we listen to their history, their signs, their symptoms, and then we do what's called a differential diagnosis. And what that is basically, oh, well, I've listened to my patient, I've assessed them. I think there could be like 5 things here that are wrong with you. And what we're now going to start to do is narrow them down. Okay, so lots of things can trigger trouble breathing, right? Or feeling shortness of breath. Lots of things, right? We've gone over plenty of those. But so we can say, okay, you're having trouble breathing, and I think maybe it's these 4 or 5 things. And then we can kind of go through their history, do any kind of test that we may need to in the back of the ambulance, and to figure out what exactly is causing the trouble breathing, so we can eliminate some of these problems. I'm having trouble breathing. Okay, do you have asthma? Have you ever had asthma? No, I've never had asthma. Okay, well, take that out. Not going to have asthma up there on our differential diagnosis board, right? So now we've narrowed the scope of what we're looking at a little bit. We can take that that condition out of the game, so to speak, right? And then narrow down what we're talking about. And then we'll have to do further diagnosis, further evaluation for assessments, things like that, and hopefully we can narrow down what our assessment is and get a good field diagnosis then. So in the field, we have to quickly rule out life threats. We keep talking about this. We got to quickly rule them out, fix them if we find them, to stabilize the patient. After we've done that, then we can figure out the diagnosis. Sometimes it's just plain as day. Sometimes you really got to dig deep and figure it out, do some real critical thinking there. Now, when we're doing this and we get a differential diagnosis, right, when we're saying, okay, it could be these 4 or 5 things that's wrong with you. In those 4 or 5 things should absolutely be the worst case scenario. Should absolutely have the worst case scenario up on the board. And our goal, hopefully, is to eliminate the worst case scenario, right? We don't want to have our differential diagnosis be like, it's just a couple of minor things. We're not going to include maybe the possible life threat here or whatever it might be, right? We want to have that worst case scenario on the board as early as possible. And so it's always in our minds, and then we can rule it out by further assessing our patient. Okay, so we want to focus on those worst case scenarios, the worst outcomes, that kind of thing when we're thinking about our diagnosis for the patient. What's the worst thing that could be happening right now that's causing this, right? Put that on the board, and then maybe some other things, and then we'll look into it. Process of elimination. We'll eliminate things off that board. The further we get into it, the more we assess our patients. So here's the deal with ours. Like we said, a lot of times doctors and doctors' offices, hospitals, things like that, they have sometimes the luxury of time, and we don't. I would venture, put the mortgage on the vast majority of EMS providers' patients that the providers have spent less than an hour with them, right? You might be in a doctor's office for an hour for one appointment, right? But we don't have the time. what we need to do is get them, figure out what's going on while we're taking them to the hospital. So the luxury of having time is not often afforded to us to do that. And obviously, the luxury of technological resources like CAT scans, MRIs, X-rays, that kind of thing, blood testing, laboratory services, that kind of stuff. It's not available to us. We don't have those luxuries, and so we've got to be very efficient, right? We've got to be really efficient with our diagnoses because we don't have the luxury of time, and we have to get them to that hospital. Right? Our environment is uncontrolled. Maybe it's snowing and it's raining, and we're outside and we're on the street, or we're bringing somebody out of the woods or something. We don't have a nice, clean, sterile environment. We don't have patients set up. Every patient's got their own little bed, and they're over there, and I can call respiratory therapy and things like that. Not only do we not have those things, we don't have the training that these doctors have. So they do 4 years post grad to get there. If you're just going to be like an ER doc or something like that, you specialize in things. I mean, it takes 10 years to become a neurologist, right, or a neurosurgeon. So our training is limited, our tool set and our skill set are limited, along with our time. So we have to be really good with what we have, with our knowledge, with our tools. We have to be efficient with our time. And our most important tool is our ability to think well, and critically think. And so we have to use our giant brains and kind of figure out what's going on, be efficient, make that differential diagnosis for those 4 things on the board, and then 4 or 5 things, and then start by process of elimination, taking some of those things off. And hopefully we can take off the worst case scenario there too as well. So we are limited in how we can approach making a diagnosis. Now, as we do the same things as a doctor, we just don't have the same skill sets, the same education, the same tools, the time that they may be afforded. So it's a little bit different, but it's the same thing. It's the detective work. Okay, it's the same thing, different scales, right? So it's the detective work, figuring out what's wrong with this patient and what the best course of action in treatment is. Now, we're not gonna be able to say like, man, you're gonna need a surgery for this, and then rehab, and blah blah blah, like all that kind of stuff. Like, I want you good while you're with me. I gotta stabilize you, figure out what's going on, and then pass you off so you can get your definitive care later. So our approaches are a little bit different. Our approach is a little bit more limited than like a physician's approach would be. And our treatments for those things are less involved as well, right? So it's not like we're sitting in the back of the ambulance like, what kind of medication can I prescribe for this person? That's not part of our treatments, right? Giving somebody a prescription. So we're a little bit limited, but it does not mean that we can't make a diagnosis or that we can't make an A+, way to go, outstanding field diagnosis. We can absolutely do that. We can absolutely do that. Okay. All right. This is where we're going to stop here. So this one was just real quick, reassessment and then diagnosis. It is the reassessment is or assessment, I should just say, it's a continuous, ongoing process. Okay, once you've done your primary and your secondary, you get right into your reassessment, basically. And again, the whole point is being on top of changes, especially for those critical patients, right? Those critical patients, we're already time sensitive. We don't have a lot of time with the patients as it is. Those patients that are more critical are more time sensitive, and so we have to be efficient. We have to go into it, the reassessment, with an open mind, being like, I could have missed something here, right? I could have missed something initially. So we have to go into it with an open mind. You have to keep your mind open. That maybe there's a possibility that we could have missed something. But at the same time, we're taking all the information from our initial primary assessment, our initial secondary assessment, and we're applying it here as well. So at that point, we got to make sure that we're not being myopic, we're too laser focused, get tunnel vision, anything like that. Still have to have an open mind that, you know, maybe I made a mistake here. So we have to go in through that assessment with an open mind. We're going into it more informed, so it can be more focused, but just go into it with an open mind. And then making the diagnosis, that's like our best, most, in order to get any course of treatment, any course, even just putting a Band-Aid on, you have to make a diagnosis. For us, sometimes it's really simple. Maybe it's just like, you have a cut, you need a Band-Aid. That's it. Right? You have cut yourself a little bit. I need to put a Band-Aid on that. But sometimes it can be that simple. Sometimes it can be a lot more complicated because of the nature of medical and traumatic injuries, medical conditions and traumatic injuries there. So making the diagnosis, we're all going to do it. And a good way to do it is evidence-based, right? You talk to the patient, what they're feeling, what their chief complaint is, what their medical history, how they're presenting in front of us, right? What do they look like? What do they sound like? You know, take all that stuff, cut it up with our training, use our critical thinking to extract differential diagnosis, right? There's 4 or 5 things that could be, and then we whittle it down with our further assessment. So quick one today there. If you have any questions, let me know. And this will wrap up our chapter 14 there. All right, thanks guys. We will we'll see you soon, and see you on the next one.